Welcome today to the normal Friday SAHMRI research seminar, but today the seminar is joint between SAHMRI, SA NT DataLink, the Health Informatics Society of Australia and the Australian Computing Society Adelaide group. Just in relation to ACS and HISA members, if you could just remember to sign the attendance sheet at the back of the room. And also just on behalf of HISA, I'd just like to draw people's attention to the HISA Big Data Conference, which will be held in Sydney in October. The theme, Big Data Analytics, Leveraging Capability in Healthcare. And if anybody has a particular interest in this area, the call for papers is currently on the HISA website, and that closes on the 15th of May. Afterwards, not normal for these seminars, there will just be some refreshments and opportunity to talk to our speaker more informally, and so I just welcome people to stay if you're able to afterwards. So look, I'll just introduce our speaker very briefly because he's got quite a lot to say and to leave talk for a lot of questions at the end. So Andrew Morris is Professor of Medicine at Edinburgh University, Director of Edinburgh University Institute of Population Health Science and Informatics, and is also Vice Principal of the university, which is sort of equivalent to a DVC. He's also Chief Scientist to the Scottish Government, and he has responsibility for the Scottish Government's health research budget of £70 million. And Andrew's been watching very carefully on the internet today the results of the UK elections and the particularly one-party result which there is in Scotland. Andrew is also Chairman and Centre Director of the FAR Institute Scotland, and Andrew will talk about the FAR Institute, which is a UK-wide institute, as part of his talk. Andrew's clinical background has particularly been involved in diabetes, and he will cover some of that as well. So, I'd like to welcome Andrew, who's going to talk about the role of big data and health informatics as part of an integrated healthcare system and contributing to more effective, efficient services and improved health outcomes. Thank you, Andrew.
Thank you, Andrew. What a great pleasure to be in Adelaide. It's my first time here, and you have an outstanding biomedical campus here and emerging around us. It's really very impressive indeed. And thanks for laying on the rain, because I feel very much at home, as you know. So today I'm going to try and convince you that healthcare is the last major industry not to be transformed by the information age, and that we are duty-bound to change that. And we need to change that. It's not only about improving the quality of care for patients and populations, it's fundamentally about the sustainability of healthcare systems internationally, because healthcare systems are fraught with waste, variation and harm, and with rising healthcare costs. And we've got to use data in a more efficient way. I actually said that healthcare is the last major industry not to be transformed at a meeting in Brussels recently, and a guy at the back, a German, put his hand up and said, "You're wrong, shipping hasn't been." But we're not in very good company, because every other industry is seizing data. So it's our opportunity to do so. And it is a big day in the UK. I've been gripped to the election results, and I've got my CV in my bag, if anyone. So what I'm going to do, I'm going to try and speak. There's your iconic building. I think what a building this is. It's just terrific. I'm going to talk about the global challenges which face us all, and ask the question, can we see a tight integration, a convergence of care and research so that we can operate at scale? And we're trying to gear the whole country of Scotland up for quality healthcare and research using data. I want to talk about the FAR Institute, give you one or two case studies, but there's some big issues here in terms of governance and patient trust. So with big data goes big responsibilities. So that's the script. Before I do that, as it's a big day in the UK, I thought I would show you a picture of the most contentious issue in this election campaign, the NHS. It's 67 years old. This was Nye Bevan in Salford General Hospital, and he says it's quite the most ambitious adventure in the care of national health that any country has seen. And it probably is. Some people think this is Mrs. Thatcher. Remember her in the bed, listening very intently. But the health service has outlasted 14 prime ministers, so we've still got it. So that was 1948. Now, in the same year, something very important on a much smaller scale was happening in this place. Chris, where's that? No, he's really coming on, the United States, yeah? Is anyone know? It's the most famous epidemiological study, arguably, anywhere. This is Framingham. Have you heard of Framingham? This is Framingham. It's a small town about 40 miles due west of Boston in Massachusetts. And it was in 1948, the same year, that all 5,200 residents subscribed to doing something pretty special. They said, yeah, we'll undergo regular health checks. There are now 3 generations of participants. It's iconic. It's produced about 2,500 papers in the world literature. But I use it because it's a great example of citizens coming together with scientists and healthcare providers to do something special. So what did they do? Through these measurements, and these are pictures of the clinics, they coined the phrase risk factors, high blood pressure, smoking, cholesterol, and diabetes, and how those relate to important biomedical events such as heart attacks and stroke. And Claude Lafont, when he was president of the NIH, suggested Framingham has resulted in an average of 4 extra years of life, which is quite a remarkable thought, isn't it, from 5,000 people. And indeed, I don't know if it's the same in Australia, but if you're sort of middle-aged like me and you go into your doctor and they do a check and they calculate your risk of coronary vascular disease based upon risk factors to decide, should I prescribe a statin or should I not? Those original quadratic equations from Framingham are used to guide treatment. So it's had global impact. And if you log on to the Framingham Civic website, they, with classical American modesty, suggest we are the town that changed America's heart. And I think they have. But we're in a new horizon now. And I used this quote the other day. So the human genome. Any geneticists in the audience? Oh, well done. I could say you're in a minority, but welcome. Because we're facing an avalanche of data. And Martin Bobrow, a mate of mine, he was governor of the Wellcome Trust, said it's rather like reaching the top of a mountain pass and seeing in front of you a fertile plain rich with new ideas, new methods, new techniques, and new concepts for understanding the complexity of human biology in health and disease. So I thought that was a great quote. And I was speaking at the Garvan with John Mattick the other day, and I said it could have been improved if it said, and informatics is fundamental to this success. Because we've got to think, how are we going to use these data in a sensible way? So that's the background. Second background, pressures on health system, chronic disease. So I'm going to take you to Scotland. We've got good data, as you have in South Australia. So these are our census data for the next, from the last 60 years or so. So just to show you how the population is changing. It's quite dramatic, isn't it? So, and this explains austerity, the pensions issues we face, because there are insufficient people here to support the pensioned population. Some people suggest this is like the profile of a North Sea ferry coming to hit us hard, because alongside that demographic challenge, we're seeing a rise of chronic disease. So here's a study from Scotland, 2 million people, where we asked a very simple question: what is the prevalence of multimorbidity in the general population? You could do this study here. So it was in the Lancet a couple of years ago. And if you look at the age of 70 to 74, which isn't old these days, few people are living with 0 or 1 chronic disease. Most people, the majority, are 2, 3, 4, 5, 6, up to 15 chronic diseases. So the complexity of disease is changing. And I subscribe to the view that this presents a fundamental challenge to the single disease focus that pervades medicine. I should be doing my diabetes clinic today because I do it on a Friday. Trouble is I'm here. But sometimes I see patients, and on the Monday they've seen the ophthalmologist, Tuesday the cardiologist, Wednesday the renal physician. And it's just not efficient. So we need to be stratifying the way we deliver care. So, and the other issue, and I was reading you've got very similar issues in terms of austerity. You've got a budget deficit. The UK is 1.3 trillion pounds in debt. So we've got to deliver better quality care at reduced cost. So this is our budget deficit. And I was surprised because I thought that you were in a budget surplus, but apparently the price of ore has gone down. Is that right? Iron ore. See, we relied on oil, and that went down as well. So we've got problems. So these are the challenges and the background where we as biomedical scientists need to think, where are we going to make our impact? So how are we responding to this challenge? One could be gloomy, and so I quite like this one, Greek debt. Believe me, carrying the world was much easier. And then, and I thought, who is a classical Scottish mythical character? So do you remember this guy? Did Dad Zarbi come? Do you remember? Did you remember? We're all doomed. But we're not doomed. There is an answer. And what we're trying to do at a systematic national level is to deliver quality healthcare and research from cell to community so that we can demonstrate better quality healthcare and costs. And we're trying to do that using data and data science as a key building block. And I think that if this is an emergent issue which will, in 10 years' time, how many data scientists in the audience? Who would say they're a data scientist? So a few. So if you invite me back in 10 years, I guarantee that the majority will be data scientists. Because if you look at how we've embraced computer science in medicine, it's been very slow to adoption. This was David Cooksey, who talked about the biomedical translational pathway, talked about the first and second gaps in translation, but he also outlined those methodologies and skill sets where we could really make a difference in terms of accelerating the quality and speed of translation. So what I'm going to do is give you some case studies to try and convince you that this is worth doing, okay? So I'm going to talk about each of those spans of the bridge, and I'm going to start with the patient, because that's really why we're here. So I'm going to give you Scotland as a case study. So I sit on the board which administers £12 billion for healthcare every year. So that's what we spend. For a population of 5 million. And although we've got various healthcare providers, we do collaborate at scale. So I should say this is the map of Scotland. It would have been like this if we'd voted yes in the independence referendum. So what that allows you to do is to take a very high level to articulate your health service on a slide. So we spend about $3,000 US dollars per capita on healthcare. We have about 16,500 beds, 12,000 doctors. You get the picture, 56,000 nurses. These are the data. And that translates into activity, so about 16 million general practice appointments, 5 million outpatients, 1.5 million hospital admissions. So I subscribe to the view of learning healthcare systems. So every patient should be participating and contributing to a research endeavor. So our thesis is that we should be capturing these data and using it not only for patient care, but also for research, development, and innovation. And we do that, and I think you've got a Medicare number, is that right? So we've got the equivalent. So this number is used for every episode of healthcare. We stole it from the Scandinavians in the 1970s. And it's derived from this is my number, so it was a big year for me last year, you can see. My date of birth. Sex, I always have to say there are not 5 genders in Scotland, okay? So Andrew suggested it was marks out of 10, which I was a bit It's a little bit upset. And then a checksum to make sure that it's valid. But what that allows us to do with good governance is follow the journey of care of individual patients across the complexity of healthcare systems. So I want to give you some examples of how we've done that. An emergency care summary. So if I'm admitted to anywhere in Scotland, my attending physician can see my electronic health record derived from my GP, and it has my drugs, my conditions, etc. About 3.5 million access per year, and it changes management in about 20% of cases. So it's very simple. So it shows you the benefits of that. A national PACS system, so instead of every hospital having their own imaging, and imaging is going to play an increasingly important role in medicine. We've converged, so we've got a single system, 24,000 users, used in 2,000 wards. You get the idea. And when we've now got an archive of 17 million studies for care and research. So you can use data. This is our NHS Scotland surgical mortality, and this is our hospitalised students. So these things are important to hospital administrators. More patient-focused. In diabetes, which is my area of interest, we've collaborated really at scale. So as of today, we have 268,154 people living with diabetes in Scotland, and we share information across all 38 hospitals and all 1,000 general practices, primary care facilities, in real time, basically. So what does that look like? It looks a bit like this. We don't rip and replace systems. It's about a data strategy rather than an IT strategy. So we agree on data standards, technical standards, and try to use the data in a logical way. So in my clinic, which I talked about, I can see biochemistry over time, I can see my patients, I can see the prescribing regardless of who's prescribed that. I can see what the podiatrist has done. I can see their retinal images. So it's that integrated care record across time and space, regardless of where it's done across the entire system. And what we've demonstrated since about 2007 is we hit about, in terms of recording of key process measures, about 95% of the population every year. So it's not bad, actually. So we don't allow people to fall through the gaps in the system. And what we've published on, these are our earlier publications, is evidence of improved clinical outcomes. So this systematic approach, these are our amputation rates, went down about 40%. This is our sight-threatening retinopathy rates, gone down about 45%. And it's my belief that if we do this systematically, we'll see a year in Scotland when we don't have a case of diabetes-related blindness. And that's good news. These are our national amputation data, so about 120 less major amputations per annum. And we published this in JAMA just a few months ago, life expectancy in type 1 diabetes. Traditionally in the States, they suggest you lose 16 to 20 years, so the mean median loss in men still unacceptable at 11 years, and in women about 12.9 years. And this is the largest study internationally, 24,000 people living with what is quite a rare disease, type 1 diabetes. So it's about using data to systematically try and improve care. And a few years ago, Mark Walport, he's our Chief Scientific Advisor to the UK Government, was the Chief Executive or Director of the Wellcome Trust. He wrote in the Times, if you live in Scotland and suffer from diabetes, you've recently been taking part in a medical revolution. I only gave him £10. It was very nice of him. But this isn't a revolution. This is what care should be like for everyone living with common complex disease. It's about knowing what's happening. It's about being informed, involving patients, and improving life expectancy. That's pretty important, and clinical outcomes. So that's the backdrop to this, but there's another benefit, and I call it the innovation pathway. And what we're trying to see is this convergence of care with research in real time. So I just want to touch upon that. So as Chief Scientist for Scotland, we've sort of publishing our strategy, and we want to do six things. First of all, build on the science, and what a great scientific environment you've got in southern Australia, I must say. Yeah. You've got terrific science here. Secondly, is this systematic collaboration between healthcare providers, academics and the public, with a significant infrastructure investment, and I'll talk about that. Thirdly is the data piece, so we use data in everything we do. Fourthly is try to improve the regulation and governance of health research. Fifthly, it's about collaborative arrangements with biotech, pharmaceutical, medical devices, digital health, informatics companies. And lastly is to be able to do studies at scale, position the country as a single research site. Because in the UK, we've got to think, what we're going to be famous for in 30 years' time? What are going to be our economies of the future? And we think the knowledge economy and health science should be one of those. And I guess it's the same in Australia, and that's why you're building this biomedical campus. So to do that, we've zoned Scotland, so we've got leadership across the patch, and we meet monthly to decide on policy which applies to the whole country. And as chief scientist, I put about 20 million Australian dollars into 5 major areas as infrastructure, clinical research facilities, safe havens for informatics, imaging, project management, and tissue. Because we think if you're going to do good studies, do biomedical translational research, these are sort of core building blocks. So to give you an idea, we've weaved together our biorepository network with an inventory management system, because I think the days of everyone having a few bits of tissue under their desk or at a freezer at the end of the corridor are gone. It's not good governance, so we've managed to weave these together and we can access these on a national scale. Imaging, as you know, each scanner presents a unique bias, so we sent a poor Glaswegian around the country to be scanned in every scanner so we could calibrate them. His headache's still pretty bad, actually. We called it Calibrain, but it means we can now do studies as a nation. We've got single regulatory sign-off now for ethics, R&D approval, and now single contracting, and it makes it a very attractive environment. The ethics approval in Scotland is 30 days, and the R&D approval now, this slide's slightly out of date. I was speaking to Mike last week, it's down to 10 days, so we can get just streamlined governance. Now, I was in Sydney, and there was this poor girl, she'd been waiting 3.5 years for her data. It's not uncommon, and actually it's a waste of the public pound. So that's what we do. So that's the backdrop. Now we'll do a bit of research and science. Does it work? So just a few examples of this in terms of clinical trials. So because of the national collaboration of clinical trials, it's attracted a lot of investment from Europe and pharmaceutical industry, because we've got the data, we've got the biorepositories, and we've got the expertise, the scientists to drive this. So it's been a bit of a success story, so much so that we've actually launched an endeavour where we want to get up to 1 million Scots to pre-consent to have to participate in clinical trials. We're up to, I think it's about 90,000 people at the moment. And what people consent to is they give permission for the NHS to check their data sets to see if they may be suitable for research projects. So we run the eligibility criteria across the data set instead of waiting for them to come to the clinic. And we're seeing success. You know, the UK used to do 10% of the world's phase 3 studies, then we hemorrhaged down to about 2% because China and Eastern Europe took over. But now we're seeing examples of first global patient, top global recruiter, etc. So it's working. It's a very simple approach. And that translates into increased activity in terms of the money, about 22 million Australian dollars worth 3 years ago, up to about $36 million. We employ about 250 people now. So the trials work. An example of this was in the Lancet 3 or 4 weeks ago. It was called the Scott Heart Study, just to show how it works. Basically, coronary vascular disease, it'll be the same in Australia. It's still a major challenge to us all. You know, in the UK, maybe traditional coronary angiogram plus exercise testing. Even if you're labeled as having non-cardiac chest pain, 6 years later, there's still a significant morbidity and mortality. So it suggests that our current modality of assessment is not as efficient as it should be. So there's a new technology. So this is an imaging one, computed tomography, coronary angiography, as you can see here. So what Dave Newby and colleagues did across Scotland said, does this new modality add value to the traditional treatment pathway? So it's a national study, as you can see, 12 centres across Scotland, and we used routine data to follow up. Okay, so this was in the Lancet about 3 weeks ago. The Americans ran a similar study, and they spent about $40 million on it. It cost us £800,000. And I paid for it as chief scientist, so I know. And the other thing is that you can recruit healthily. You know, we recruited 47% of all eligible patients, so which is, again, efficiency of the trial process. And most importantly, these are the data. So this is how computed tomography, coronary angiography impacted upon the CH death and non-fatal MI rate, and this includes stroke. It changes the diagnosis in 1 in 4, changes management in 1 in 4. So it's a case study of using that infrastructure to answer really important questions. Secondly, evaluation of policy. Evidence-based policy would be nice, wouldn't it? So the smoking ban. Do you have a smoking ban here in public places? Did it work? So again, these studies cost about, this one on the right cost about 12,000 Australian dollars to do. Jill Pell and colleagues in Glasgow, she published it in the New England Journal, said, after the ban, what was the impact upon hospitalizations for asthma in 5-year-old children, to see if there was any beneficial or detrimental effect of the ban. So it's shown schematically here. Before the ban, a natural increase in asthma, 5.2% per annum. After the ban, 18% decrease. So now using routine data to actually evaluate the efficacy of policy. And I have to say it's not confounded, because even in Scotland, 5-year-olds don't smoke, okay? So just to be clear about that. What about diabetic retinopathy screening? We arbitrarily say, you've got diabetes. Any diabetes folk in the audience? What's your screening interval for retinopathy? So, pardon, is it annually? Yeah, so, and we say, everyone, if you've got diabetes, you should be screened annually. We don't know if that's right or not, but so this is a bit of a busy slide, but basically we're trying to use our own data to stratify patient pathways. So again, we looked at big numbers, and we answered the question, if you've got no retinopathy, can you increase the screening interval? So if people with type 2 diabetes have 2 examinations showing no visible retinopathy, it's quite safe to offer them 2 yearly screening. So you can stratify patient pathways using phenotypic data. And this is really important because that group's large, so you actually, in terms of your screening episodes, you can screen 44% fewer people. Now, as a doctor, and you know what medicos are like, if because of the increasing numbers of patients, they say we need more cameras, more graders, more activity. But actually, you refine the activity you have, so it's more precise in terms of patient need. National programs, and I'll touch upon some of these later. We collaborate with Genomics England, Francis Crick Biobank, etc. But the question is, it goes back to this economic growth argument. Can we scale this model internationally? And one example, which is still ongoing, about 6 years ago, I was invited to go to Kuwait, another small oil-rich nation, because their prevalence of diabetes is 25%. It's just really challenging. So we put this package of research, education, skills, and informatics in. We also took our national dress to Kuwait, as you can see. And we used data they had to produce the same sort of picture of, this is the Kuwait Health Network, very similar to the Scottish one. So you can do this at scale. And we've underpinned that with research quality improvement programs. We've graduated about 100 MSc students to try and, so it shows you can export this capability. And with your position in Asia, you know, I think there's a huge opportunity to support other countries to develop their health systems. And lastly, this is specifically for you, my genetics friend. Okay, so you're pleased. Pleased to see you're on the front row. What about genomics and precision medicine? So it's the same model. I've talked about phenotyped cohorts, talked about the population denominator. Can we use the same model to run genomics? And yes, you can. So here, this was some stuff we published in Nature Genetics, looking at metformin. So we run, this is an old GWAS study, we ran a GWAS across metformin response, and using routine data, because we know people with diabetes, we know who got metformin, concordance with therapy plus therapeutic response, we were able to look at genetic predictors of response, because as we manage disease, the precision of the drugs we use is not very precise. An old professor of clinical pharmacology used to say to me, "Morris, it's easy. If you give a drug to 10 people, 3 respond, 3 don't respond, 3 don't take it, and 1 has an adverse event." And actually, if you go to your doctor and you're given an antihypertensive, it is a bit trial and error. We actually don't have the knowledge. So what we're trying to do is to use molecular data to stratify patient treatments. And we're in the foothills of where we need to go, but this shows you how one can use routine data to understand new biology, because we found out that common variants near this ATM gene are associated with metabolic response to metformin in type 2 diabetes. And this was interesting because ATM was unknown to us, but are there any cancer biologists in the room? Because everyone knows about ATM, it regulates cell cycle regulation. And now this and other data have led to, there are now, I think it's about 140 clinical trials internationally looking at the use of metformin, a drug we use in diabetes, for cancer. And as I suggested, we're seeing a rise in the use of genomic technologies. So in England, we're sequencing 100,000 whole genomes in 5 years. And we hope to partner with Genomics England. And we've set up an innovation centre in Scotland, which brings the industry together with academia and the NHS to do whole genome sequencing and precision medicine across the board. And the model is the same. So I've talked today about imaging, about e-health data sets, but also molecular characterization. And we're creating a business platform to allow this to happen so that either academics or companies can come in, create inception cohorts and look at stratification to treatment. And this is the Informatics platform. We've spent a lot of time on this, a safe, secure, private cloud, scalable, hosted solution for the computer scientists, which provides collaborative work spaces for varied computing and analytical needs, an open architecture with elastic compute, and integration with a whole variety of genomic platforms. This is really state-of-the-art computer provision, but it also enforces those safeguards so that private data remains private and research data remains accessible for. So we have a big data infrastructure at a national level to deliver this. We also, this is our big hospital. I thought I was proud of it until I saw yours, actually. So this is in Glasgow, and within that it's very similar. We've got an imaging suite, and we've got an innovation centre which brings academia, NHS, and industry together to do that. And precision medicine appears to be the rage. This is Obama launching his cohort of 1 million people. He's put about 200 million people into precision medicine. And a thought is this is going to require really deep international collaboration, because as and maybe, I don't know if you'd agree, but as we learn more about the molecular characteristics, especially in cancer, but also other chronic diseases, what strikes home is the heterogeneity and complexity of these diseases. So I think this is a very sobering study. This was in Nature from Mike Stratton's group a wee while ago. They looked at 21 cancer types. So that's like tumor sites, breast, ovary, lung, prostate. And they asked a very simple question in 4,700 people. What is the commonality of mutation rate in those tumors? And the bottom line is it's not common at all. So every cancer is different. Only in 13 genes, look at all these genes where mutations, there is a greater than 5% commonality in mutation rate in these cancers. And I think this will require international collaboration and data sharing if we're going to try and understand the complexity of these cancers, which will allow us to guide therapy. And that's why the Global Alliance for Genomics and Health has been launched, which looks at the safe and trustworthy of sharing of genomic and clinical data across organizations, methods, and countries. So Kathy North, you may know from Melbourne, is leading this. So that's a really useful website for a lot of good standards, governance type stuff. So I'm going to finish by talking about 5 big challenges in this space. So the first is this thing about, this is going to be a lot of data. It's not particularly at the moment, but it's going to be. 3 gigabytes for a whole genome sequence. So we're going to need capacity building and alignment of computer science and mathematics with medicine. This is going to have to happen if we're going to make inroads into this. And as I suggested, the days of all us having a little server at the end of our corridor, I think, has to go, because this has to be done at scale. Other industries have done this, so-called software as a service, platform as a service. You have a subscription model for your compute rather than having to build it yourself. Because this is the future of medicine. I hope you like this slide, so I'll do it again. There we go. Because it's going to be pretty complex. Because if we're going to really tackle and understand disease, we're going to need to integrate personal data. Most data aren't held by health systems. It's going to be gathered by Apple Watches and other such stuff. Genomic data, imaging data, and I think, in 20 years' time, the characterization of disease will require that tight integration. The second big issue then is, if this is going to work, how receptive are our health systems to actually embrace these data? And the bottom line is not very. I'm sure you've had many seminars in this room which have talked about personalized medicine, prescriptive analytics, clinical risk. But we need mature health systems which are receptive. So this is a pretty blunt grading scale, an instrument which we use to measure the maturity of health systems. Everyone wants to be at level 8, but most people are down at a very much lower level 1 or 2. And one of my jobs at UCL Partners was to look at this. So across Europe, we were sitting at 2.3, Germany's 1.7. America's ahead of the curve at 4.4. This is very hospital-based, though. It's a blunt instrument. The bottom line is we need to get biomedical informatics into our hospital systems. We need to move beyond the IT department. The third thing, and this is pretty ambitious in the UK, we want to deliver this at scale. We want the UK to be really, really, really famous at this stuff. So the funders have put about £100 million in and are looking to do the same again. And part of that investment was into something called the FAR Institute. And I'm a team of 4, so we've set this up, named after William Farr. So we want to set a really high standard in the trustworthy reuse of data. And I think the work that you're doing in Australia with the Data Link is, you are seen as a global leader in this space. I think the opportunity to bridge further than that into the biomedical space is a great opportunity. So this was William Farr. He insisted the cause of death was put on death certificates. He was a UCL graduate. And he predicted precision medicine. Diseases are more easily prevented than cured, and the first step to their prevention is the discovery of their exciting causes. So what we're doing across the UK, so that's London, Wales, Ronan in Wales, myself in Scotland and Ian in Manchester, are trying to gear this up at scale across leadership, research, engagement, etc. So what have we done? We've enabled new data sets. We've put in this private cloud infrastructure, a telepresence. We've also built what I've called research hotels. So this is ours. I thought my building was nice. This is Edinburgh, where I work. So what we've done is brought all these universities together with NHS and increasingly with industry to breathe the same air, to have an interdisciplinary environment. And it's really good. It works, you know. So the best thing about this building, which I'm sure doesn't apply to your own here, is that we have free parking, as you can see, which is always very popular. And we've done that in London. So sorts of things we're doing. In the UK, there are 2.2 million consented people working in 34 cohorts. We owe them a great debt of gratitude. And what we're doing is using routine data to link this biomedical data at scale for up to 2 million people, scaling the effort. The fourth big issue is, and I think this is the most important one, any computer scientists in the room? There's about 4 definite ones and 2 uncertain ones. There we go. That's Bayesian, isn't it? So, but I think this is going to be really important for medicine. It goes back to my point that we haven't seized this. So this is my mate Dave, who was Dean of the School of Informatics. These are the top 10 UK computing science universities by research power. So this is us in Edinburgh, in our ref, world leading and internationally excellent. And what we're seeing in computer science is a parallel surge in new methodologies, whether that's robotics, sensors, natural language, machine learning, data linkage, data architecture, social computation. But we're also seeing a confluence in those methodologies. The risk for us is that they remain in computer science. So what we've done is Dave and I now share an office because we need to understand each other's worlds. So what we're trying to do, this is the world of medical informatics. I've talked about physical data, organizational data, and personal data. We've brought the organizations together, whether it's the NHS, etc. And we're deploying these new technologies and focusing them on new therapeutic interventions, effective personalization, integration in real time. So it's this confluence of healthcare and computer science. And we've put a considerable amount of physical presence into this. So this is the Higgs Center, this is astronomy and physics, this is the Roslin Data Technology Institute and ourselves. And across Edinburgh, we've probably put about £120 million into this space or won that amount of money. So this is a huge investment over the last two years. And what we've seen alongside that, so this is, anyone been to Edinburgh? It's a lovely city. Oh, it's quite popular. So this is a Google map of Edinburgh. These are the university locations. What we've seen is a cluster effect. So these are companies which have either relocated or spun out or spun in. And we're contributing to our local economy through this endeavour. And lastly, the biggest issue of all, and it goes back to this comment, with big data goes big responsibilities, because there's a lot of personal issues in this, privacy, public benefit, where does the balance lie? I think Edward Snowden did us a favour. You know, I think that we need to be on the front foot in everything we do in engaging the public to guide us through big data, so that we design for transparency and trust. And we've been very fortunate. We've worked with the lawyers. This is Graham Laurie, Professor of Law, who's guided us through the legal aspects of this. We've also worked tirelessly with public engagement and participation. I was delighted to see the public coming through this building today. I think that's really important, you know. But we have a similar approach. And they try to, well, we ask their advice about proportionate, transparent data use. And it means we've escaped, touch wood, many of the scares elsewhere in Europe. And underpinning that, we've got policy at national level. So the Scottish Government has a data vision or a data strategy for Scotland. It's defined the technical approach in terms of its data strategy, and these are a bit busy, these slides, but I'm saying that we've also got government support and policy to allow us to do this type of activity. And recently we just published our Health and Biomedical Informatics Strategy for Scotland, which is a charter about how do we federate these safe havens of data analysis, how do we remove duplication in governance, how do we enhance data, etc. And that's our federated network. And we've come up with this notion of proportionate governance so that authorization is based upon the baseline risk of the project. And we have a single privacy committee now which looks at all of these proposals. And the turnaround time is targeted at 20 days. So I'll skip that. So to conclude, can I thank you for inviting me? I do say Adelaide is a beautiful city. But are we going to make this work? I've come up with sort of 8 C's for success. And number 1 is the commitment to public engagement in everything we do. Number 2 is this convergence of care with innovation and research. And your new campus here should surely give you the opportunity. The hospital's there. It's going to be great. Clinical focus and patient focus has to be the number 1 priority. I'm a great believer in forging collaboration across healthcare providers and industry with academia. This issue around computer science is going to be vital. The digital maturity issue needs leadership within healthcare sector. And lastly, clarity about governance and data sharing. So I was delighted to come to Adelaide because of the outstanding work that you've done in this space over many years, but I would suggest there is an opportunity for Australia also to lead the way in this space. So if you do invite me back, because I was 50 last year, if I come back in 50 years' time, I thought, you know, how will we get there? So I quite like this one. The only place where success comes before work is in a dictionary. But then I saw it was a very famous hairdresser who said it. So I thought I can't finish there in Adelaide. So I thought I'd look to North America for some inspiration. Do you remember Dan Quayle? Do you remember him? If we do not succeed, then we run the risk of failure. So I wasn't too keen on that. So I thought I'd finish with the maestro, because this stuff is difficult, but there's huge opportunity. And I think we're going to have fun along the way. So thank you for listening. In your beautiful city. And just to flag that we're all meeting in St Andrews, another beautiful spot, in August this year for our international conference. And I think that 1 or 2 folk are coming, we hope. So thank you very much.
Okay, thank you very much, Andrew. We've got about 15 or 20 minutes for questions, and then, as I said, Andrew will be here for a little while afterwards for some more informal opportunity. So, James.
Thanks very much. That was a marvellous representation of a can-do approach. All too often in working in this sort of general area in Australia, one encounters a can't-do approach, particularly at sort of middle administrative levels. How do you fix that?
Yeah, no, it's a good point. There's varied. It's multifactorial. We've got a very strong leadership team across both academia, health service, plus in government now, because in chief scientist. Secondly, smiling persistence is very important. Thirdly, focus on the patient, because a lot of people say, oh, you can't do that. But when you have data and you actually show that people's lives are improving, then it's more difficult, even for the sclerotic middle management, to say, well, actually, I'm not going to subscribe to this. Also, I think Scotland's tractable, because you can get most folk with an interest in an area into a room, and it's a small room. And that's why I think Southern Australia is tractable. It should be, because, you know, what's your population, 1.3 million or something? Yeah, so it's a great size. It's a great size. So it's multifactorial. And we're not there yet. There's still sludge in the system, but we're beginning to demonstrate a bit of value, I think. I also think that if you design this stuff by committee, it just goes on forever. So what I like to do is to do exemplar or demonstrator programs. So start small, think big, move fast. So that in 3 to 6 months you can say, well, we've got some data here. So very, very driven by the data as well, which you use to explain and try and convince rather than coerce folk. So.
Thanks for your talk. The whole of Britain, with about 60 million people, I think, isn't it, fits into Queensland about 6 or 9 times. And the whole of Australia is equivalent to the whole landmass of Europe or the whole landmass of USA. So we're a totally different geographical situation here with 23 million people.
Yeah.
Do you have any clues on how we can overcome this obstacle of geography?
So for what outcome?
Same outcome as you.
Oh, right, okay. Well, even in Scotland, we've got our, well, what we call remote places. They're just down the road to you. But I think it's identifying coherent clusters and then trying to get the leadership together across the space. Saying that you're 23 million people, most of them are, I'm not a geographer, but I understand most of it, 80%, 90% are within 5 or 6 urban conurbations. So I think this issue of trying to get tractable geographies working together is a good approach. In terms of the remote and rural stuff, I think Canada's making a big play on the digital health, telemedicine, and I think that will be an industry that could be pioneered in somewhere like Australia, because then if you can demonstrate safety and improvement of clinical processes in your geography, that undoubtedly will have ramifications in less disparate organisations. It's about the people at the end of the day, isn't it?
How did you overcome some of the data governance challenges and duplication standards between medical records and medical information before it's come together to be able to use those data?
So I think the question, this is a test for me, is how did we come across well, there's 2 questions there. Firstly was the governance question, and secondly was the data standards question. Is that right? So governance, a few years ago, to get that amputations study done in Scotland, someone had to go to 23 committees, and it took them 18 months. So I thought, let's do a bit of case law. So we just asked for people just to describe, not in a judgmental or pejorative way, what their experiences was of seeking approvals. So there was this poor guy in Edinburgh who was linking the Lothian birth cohort to educational attainment, and he had to submit 240 documents. So we just built case law, and we said, well, look, this is how efficient we are. And that was very powerful in actually people saying, well, actually, we do need to streamline this in a so it's the same folk making the decisions, but they're making the decisions across a broader canvas, and they have delegated authority to do that. So that was good. In terms of the data quality is a big issue. I've got a sort of talk on that, but I didn't show it. So it's tricky, and there's always going to be data quality issues, but don't allow the perfect to be the enemy of the good. And we also try and carry the provenance of data through the integrated system so that people can actually go back and look at the metadata and make their own mind up. So.
Thanks. I've got a 3-part question.
I'd better write it down.
Yeah, try and keep up. The first part is, how do you get the government will, especially as governments change frequently? It seems that something like this requires a lot of will politically, if it's to succeed. The second part is essentially dealing with spatial component of the data. Bringing together big data provides enormous an opportunity to do spatial analysis at a detailed scale. So it's not just about what's happening at the national level, but how are some of these things distributed, and are those patterns related to elements within the built environment? And the third part is, you know, how does one get a job down there? That's just fabulous data.
And I'm coming here. So, well, we actually, at the government level, you know, it's probably different in Australia, but government services or public services are known to be pretty inefficient, actually. Is it different here? So, and you know, if you believe people like McKinsey, they say that average health systems are running at 60% efficiency in terms of the money you're putting in and the benefit you're getting out. So I think both at UK and at Holyrood, we had leadership from ministers who said, David Willett said, I want big data to be one of Britain's great 8 technologies. So he defined carbon capture and storage, all this stuff, and big data. And we also have in Scotland ministers who said, yeah, we will have a data vision for Scotland. You know, I think the political parties, politicians can shy away from this stuff because of the privacy debate. But you can cause great harm in society by not sharing data. So it's getting that balanced approach. So we have been fortunate to get political support for this. In terms of spatial data, that's a good point. A slide didn't show, actually. In that very nice building in Edinburgh, we've also co-located our social scientists who look at transport data, air pollution data, educational attainment data. Because a lot of causes of poor health lie out with health. So we have the ability to link into these spatial data sets. So we've published, Dave Newby published on coronary vascular disease and air pollution, for example. So yeah, it's not only the biomedical focus. And the thirdly, just dust down your CV and give it to me on my way out.
Hi Andrew, James Dodge from Population Health.
Yep.
I've got 2 questions for you also. The first is that you seem to have done a fantastic job of linking within health. Where are you at with linking to other sectors, other social services, etc.?
Okay, so that's a good question. So it reflects a little bit on that answer, is that health and social care integrations now government policy, so we're having to do it. So we're linking to educational services, even with very robust privacy approvals, authorization, anonymization to stuff like pensions data, work and pensions, and HMRC, which is our revenue data. So we are, yeah, we've got the infrastructure in place that's now doing that. So.
Excellent. Well, my next question kind of leads on to that privacy point, which is that, forgive me if I'm wrong, but you seem to be somewhat hamstrung still by working within a framework of informed consent. Is that correct? And if so, what do you think the prospects are for moving beyond that?
No, it's opt-out. It's not. It's opt-out with, well, it's opt-in for any study which is intrusive, if I put it that way, in terms of use of tissue or clinical trials or that type. But the use of data for unintrusive epidemiology outcomes improvement is opt-out, with public campaigns to say, this is how we use the data, this is why we use it, and these are the safeguards in place to make sure that we don't, you know. So people come to the data. I didn't go into the technology. The stack is like a reading library. People come to the data rather than being sent data. So we've got various approaches to ensure those safeguards are as resilient as possible.
I was wondering about what the patients think. You mentioned before that you get a lot of your buy-in by the fact that it's patient-focused. Yeah. And I imagine that's applicable to the social services, which other people have mentioned as well. So the public and patients are great. If you sit down and explain it, they say, well, yeah, we see the benefits of that. And I'm a great believer in advocacy, so publics, because the public is not a single entity, are advocates for what we're doing. Plus what I call the third sector, the charities, you know, especially there was a Heart Foundation event on here before this seminar. You know, they are really well respected, and if you build a coalition with the publics and the third sector, I think that's really important. Okay. I'm conscious of time. It's, I need to see how many seats.
Well, thank you very much, Andrew, for sharing with us the story of what is being worked on in Scotland and the challenges and opportunities that that might present for us here in South Australia. And we would just like to offer you a small token of appreciation, which is a small piece of South Australian art to take back on the plane with you this evening. So I'd just like to thank Andrew.
That's very kind.